So, hello everyone. Thank you so much for coming. I'm McKenna Campbell, and I'll be your host tonight. A little bit about ACS. It's an international association of healthcare professionals. We're on the forefront of the cannabinoid medicine. It's been founded by physicians, so ACS is uniquely positioned to advocate for the highest standards in the practice of cannabis medicine. We are also an advocacy organization striving to guide lawmakers and regulators at every level of cannabis control. We also prioritize inclusivity and value having memberships from all walks of life, which motivates us to provide discounted memberships to qualifying groups, as you can see on the slide. On this next slide, you can see that there are many benefits to joining ACS. For all of ACS's constituents, we provide evidence and experience-based education to support the premise that cannabis should be treated as medicine. Please feel welcome to reach out to us with any questions about membership or our free student memberships. For our student leaders, we do encourage you to learn more about our student ambassador program and get involved. And now, talk a little bit more about our speaker, Deondra Asike, MD, is a double board certified in anesthesiology and pain medicine. Since 2015, she has been clinical associate, Department of Anesthesiology and Critical Care Medicine at Johns Hopkins. Dr. Asike is also currently serving a second term on the Maryland Department of Health Prescription Drug Monitoring Program Advisory Board. Additionally, she chairs the Maryland Cannabis Public Health Advisory Council and the Maryland State Medical Society Cannabis Committee. She is also a specialty expert and Maryland spokesperson for Doctors for Drug Policy Reform. As a certifying provider with the Maryland Cannabis Administration, Dr. Asike, I keep saying that wrong. Asike believes strongly in a holistic approach to chronic pain management that includes proper nutrition, physical therapy, behavioral therapy, and cannabis as medicine. In 2022, she founded National Pain Relief, a consultation practice primarily focused on guiding both patients and members of their healthcare team through a safe and effective incorporation of cannabis into a comprehensive pain treatment. Dr. Asike is also a veteran of the U.S. Air Force. She was deployed to Bagram Air Base in Afghanistan in 2013. And now, for the fun part of tonight, I will turn it over to Dr. Asike for her presentation and stop sharing my screen.
Thank you for that kind introduction. It's great to be with you all this evening. All right, thumbs up that you can see my screen. Perfect. It's a pleasure to present to you today on the topic of communicating cannabis use before surgery. And without delay, here are my disclosures. Let's begin at the bedside this evening with a clinical scenario. Feel free to participate by dropping comments in the chat function, and there will be an opportunity at the end of the session for questions at the end. So Chuck Jones is a 55-year-old male in your office today for his preoperative evaluation. He is scheduled to have a bladder biopsy under general anesthesia. In reviewing his past medical history, you learn that he has hypertension that is controlled with medication and acid reflux managed with diet. He runs 3 miles every week. What else would you like to know about Chuck? And again, feel free to comment on what else you would potentially ask a patient like Chuck, scheduled to have anesthesia. Do we have any participants in the chat box, Kelsey, for you to read the response?
One person asked what drugs and NPO status. Another one mentioned allergies.
Perfect. So he mentions he does not have any allergies to any medications. He's had anesthesia in the past, and he's happened to have post-operative nausea and vomiting. As I mentioned, he has excellent functional status. And the other question was, his NPO status. He has not had anything after midnight. Is there anything else you'd like to know about Chuck? Were there some additional comments added in the chat?
There were. What non-prescription meds does he take? medication lists, supplements, prior surgeries, and cannabis use.
Very good. So being the astute and thorough clinician that you are, in a very non-judgmental tone, you ask, do you use alcohol, tobacco, cannabis, or herbal supplements? And he says, why, yes. I smoke marijuana 1 to 2 times per day to relax my nerves. But why, doc? Why do you ask? Does my marijuana use matter? Of course it does. And believing that better patient outcomes begin with education, my overall goal this evening is for you to leave this discussion more informed and empowered to discuss cannabis use with your patients having surgery. I will review proven and hypothesized physiologic effects of cannabis, especially those of particular importance in the perioperative period, while providing you with practical suggestions to guide your pre-anesthesia evaluation and assessment. Lastly, I will help you to better understand reasons to consider cancellation or postponement of elective procedures. This presentation will not cover considerations specific to pediatric or obstetric populations. But first, as a level set, I want to define important terminology used in the field. The term cannabis refers to the plant species Cannabis sativa L and its components. The primary medicinal components of the cannabis plant can be classified as non-cannabinoids and phytocannabinoids. And of the over 100 phytocannabinoids that exist, the 2 most studied are delta-9 tetrahydrocannabinol, abbreviated THC, and cannabidiol, abbreviated CBD. As cannabinoids, THC and CBD demonstrate activity at cannabinoid receptors. Endogenously produced on demand are the prototypical endocannabinoids anandamide, abbreviated AEA, and 2-arachidonoglycerol, abbreviated 2AG. And falling under the category of synthetic and semi-synthetic cannabinoids are drugs of abuse such as K2 and spice, cannabis-based medications, and cannabis products. Regarding cannabis-based medications, to review, dronabinol, nabilone, and Epidiolex are examples of cannabis-based medications available here in the United States. Dronabinol, known by its brand name Marinol, is a THC analog, FDA approved for AIDS-induced anorexia and nausea and vomiting caused by cancer treatment. It is taken orally and it is listed as a Schedule III substance. Nabilone, whose brand name is Sesamet, is also a THC analog that similarly to dronabinol is taken orally and approved by the FDA for chemotherapy-induced nausea and vomiting. It differs from dronabinol in that it is listed as a Schedule II substance. Epidiolex is the brand name for cannabidiol, but it's only available for purchase by the brand name Epidiolex. It is a plant-derived CBD oral solution indicated to reduce seizure activity in those with certain seizure disorders. This medication is unscheduled. If you live outside of the United States, say the United Kingdom or in Spain, you may have access to nabiximols, whose brand name is Sativex. It is a plant-derived medication composed of CBD and THC at a balanced ratio of 1:1. And it comes as an oral mucosal spray indicated for symptoms of multiple sclerosis. These symptoms include neuropathic pain, muscle spasticity, and overactive bladder. Finally, cannabis products. They are available in state-regulated dispensaries, and these products include raw or dried flower, tinctures, oils, capsules, edibles, topicals, and suppositories. They can be administered by a variety of methods, so some are inhaled, meaning they are smoked or vaped, while others are ingested or absorbed transmucosally or transcutaneously. Their pharmacokinetic profiles are dynamic, and depend on several factors such as route of administration, chemical profile, and concentration. And I will emphasize now that THC is the cannabinoid most often implicated in the studies that I will present. I will note that the physiologic effects were either demonstrated in vitro studies or in human studies where cannabinoids were specifically smoked, making it hard to extrapolate these findings for other routes of administration. Additionally, exact mechanisms that mediate each effect are not well defined or understood. Now to begin our review of the physiologic effects of cannabis. The central nervous system effects can be categorized into acute and chronic use effects. Acute use is defined as recent use, typically within the last 24 hours. These effects include altered mental status and dose-dependent impairment of cognition, THC more so than CBD. And you can imagine, if these are present, it would make it difficult to obtain informed consent for surgery and anesthesia. Acutely, we can also see anxiety, paranoia, and analgesia. There's questionable psychosis. Really what we believe is it can destabilize those with psychosis. But you can also see acutely changes with cerebral vasculature, notably cerebral vasodilation and increased cerebral blood flow. With chronic use, we start to expand this list to include the development of tolerance and risk of experiencing cannabis withdrawal syndrome. Suggested, but not yet proven, is the formation of hyperalgesia. Hyperalgesia is the term used to define an exaggerated response to painful stimulus. Cerebral vasospasm and vasoconstriction are postulated to be triggers for ischemic stroke events. Cannabis-induced cardiovascular effects are believed to be biphasic, also characterized as acute or low-dose effects where the sympathetic nervous system dominates, and chronic high-dose effects where there's an increased parasympathetic tone. So you can have associated bradycardia and hypotension. Our understanding of cannabinoids, specifically THC's effect on the cardiovascular system, come from studies in which cannabis was smoked or synthetically derived. Tachycardia and elevations in blood pressure occur more frequently than lethal dysrhythmias. Retrospective studies have concluded that the increases in heart rate and blood pressure are greatest within 2 hours after smoking cannabis. Additionally, MI symptoms were also greatest during this time period. It is unclear at this time whether cannabis alone is a trigger for acute coronary syndromes. Acutely, inhaled cannabis is associated with many respiratory effects, to include bronchodilation, airway hyperreactivity, as well as pharyngeal and uvular edema. This edema is reported to be lessened at 72 hours after smoking cessation. Interestingly, one study noted that bronchodilation occurred after oral consumption of THC. Chronic inhalation contributes to airway flow obstruction, hyperinflation, hyperreactivity, and airway inflammation, which is particularly harmful for patients with pre-existing reactive airway disease. Long-term cannabis use can contribute to the development of symptoms consistent with chronic bronchitis. Cannabis is used to treat a variety of gastrointestinal symptoms. I previously mentioned the FDA-approved cannabis-based medications Marinol and Nabilone, indicated for chemotherapy-induced nausea and vomiting. But cannabinoids also display inhibitory effects on GI motility. In fact, many patients with diarrhea-predominant bowel disease find that cannabis decreases their symptoms of diarrhea and abdominal pain. There is lack of evidence linking the inhibitory effects of cannabinoids on gastric motility with increased aspiration events in the perioperative period. Cannabinoid hyperemesis syndrome is a condition characterized by severe cyclical nausea and vomiting, along with abdominal pain, resulting from frequent, long-term, usually greater than 1 year, cannabis use. Hot showers characteristically provide relief of symptoms, but the only consistently proven treatment is to discontinue cannabis use altogether. A two-center retrospective cohort study identified daily cannabis use as a weak risk factor for the development of postoperative nausea and vomiting. But in their conclusions, the authors discouraged us from changing our current approach to post-op nausea vomiting prophylaxis on the basis of chronic cannabis use alone. I will briefly mention that regarding the risk of bleeding, there have been variable and contradictory reports on the direct effect of cannabinoids on coagulation and platelet function. However, cannabinoids can inhibit cytochrome enzymes involved in the metabolism of antiplatelet and anticoagulation medications. I will speak more about this in an upcoming slide. Chronic heavy use of cannabis has been associated with postoperative hypothermia and shivering that is reversed by the CB1 receptor antagonist rimonabant. So it's possible that cannabinoids, specifically THC, may potentiate hypothermia caused by inhaled anesthetics. Now to incorporate our understanding of these effects and how we approach patient care in the perioperative period. Back in January of last year, the American Society of Regional Anesthesia and Pain Medicine published evidence-based guidelines as a tool for our decision-making and management of those who consume cannabinoids. Their recommendations are not a standard of care, but a framework to help us provide safe perioperative management to surgical patients. I highly recommend that you take a look at this. A major highlight of these consensus guidelines was the Grade A recommendation for healthcare professionals to screen all patients for cannabis use. This is important so that we can better understand the cannabinoids used, if known, the method of consumption, the frequency of use. A Canadian panel of experts defined significant use as greater than 2 to 3 times per day of unknown cannabinoid content. Amount use, this same team defined significant use as greater than 1.5 grams of whole flower inhaled, greater than 300 milligrams per day of CBD oil, and greater than 20 milligrams per day of THC oil. We also can inquire on the time of last use and the indication of use. Urine toxicology, as we know, is inaccurate in its ability to detect acute cannabis use or intoxication. And the authors made it clear that universal toxicology analysis prior to surgery is not recommended. Here is an example of how cannabis use is documented in the adult preoperative evaluation template where I practice. Being more scientifically accurate, cannabis has replaced the term marijuana, and we are now more accurately documenting method of use and frequency. Cannabis use can be documented in 2 sections as appropriate, in the pulmonary section and also in the psychosocial section where there are other medically relevant substances listed. You can also double click on any of these boxes to allow for free text if you wish to enter the amount or cannabinoids known to be used. So next, to incorporate what is understood from the publications to date, I'd like to walk through some of the questions that I'm asked and how I approach patient care prior to surgery. So I'm asked, do any of my medications interact with cannabis? Well, THC and CBD are metabolized by the cytochrome P450 enzymes, and it's important to recognize that these cannabinoids are also inducers and inhibitors of cytochrome enzymes. Patients on antiplatelet and anticoagulation therapy are particularly susceptible to these effects with CBD more so than THC, inhibiting isozymes 2C9, 3A4, and 2C19, which metabolize Coumadin, the direct-acting oral anticoagulant such as Eliquis, Xarelto, and Plavix. Potentiated CNS depressant effects can occur when cannabinoids are taken with opioids, alcohol, benzodiazepines, and antihistamines. But potentiation of respiratory depression does not seem to occur when cannabinoids are used alongside these agents. Penn State has created a useful cannabinoid drug interaction checker, and I've included their link here on this slide. Feel free to share in the chat function a checker that you may use. In clinical practice, many potential drug interactions may be avoided by staggering medication doses 1 to 2 hours. So moving on to the next question that I'm asked, and there is an opportunity for audience response if you have an iPhone or an iPad for this next section here. So since I use more cannabis, does this mean I will need more anesthesia? Again, if you'd like to participate, feel free to scan the QR code here listed in the bottom left hand of the slide. And so do you tell this patient who's asking you if they'll need more anesthesia? Yes, they will need more anesthesia. No, they won't. Maybe, or I don't know. We'll take a few moments to allow you to enter your response. Any more takers for this answer? Well, overall, there is weak evidence to conclude that all those who use cannabis will need adjustments made to their anesthesia. And there is no evidence to support intraoperative EEG monitoring or the BIS monitoring. It does not accurately monitor depth of anesthesia just based on whether or not the patient endorses cannabis use. But I will add that anecdotally speaking, prior to airway manipulation for smokers of any substance, nicotine or cannabis, I routinely administer additional induction medications such as propofol, and that's really just to suppress the airway reactivity. And it is possible, but not yet proven, that cannabinoids, similar to, say, substances such as alcohol, and that the timing of last consumption matters and the amount and chronicity of use matter. Heavy and chronic use results in cytochrome enzyme induction and the development of cross-tolerance. And what we already know, and again, an example is with alcohol, that with acute use, your anesthesia requirements or your MAC is decreased. But with chronic and heavy use of alcohol, your MAC or your anesthesia requirements is increased. The next question that this patient asks you is, will my pain be more difficult to treat because I use cannabis? So again, if you'd like to participate in this question, feel free to scan the QR code. Do you tell that patient, yes, because of your cannabis use, it's going to be hard to treat your pain acutely? No, it's not, or possibly. Thank you again for your participation there. THC does not consistently appear to display opioid-sparing effects in the setting of acute pain. Chronic cannabis use, similar to chronic opioid use and chronic alcohol use, appears to contribute to the development of tolerance. It has also been suggested, as I've mentioned before, that hyperalgesia forms as well with chronic cannabis use. So there is a possibility that, cannabis users may endorse higher pain levels postoperatively, but it has been documented and demonstrated that this may or may not translate into them needing an increased amount of opioid medications. I would personally add that for the chronic cannabis user undergoing a non-ambulatory procedure, meaning these are patients who are not going to be able to go home right after their procedure, the acute pain experience is further complicated by a lack of or limited access to cannabinoids while they are inpatient. The North American Spine Society Journal published that in chronic cannabis users, there was no increased opioid prescription fulfillment following single-level anterior cervical discectomy and fusion. Their study was focused specifically on the acute post-surgical period at time periods within 90 days. So what this study suggests is that when patients have access to cannabis as medicine, or that access is restored, they stick with cannabis and they don't necessarily require higher amounts of opioids, more so than those who don't use cannabis. With all of this in mind, it is an ASRA grade A recommendation for us to discuss considerations specific to acute pain management in those who have a history of heavy and chronic cannabis use. Ideally for all patients, your treatment plans would be multimodal, individualized, appropriate to the patient and the procedure. And I want to highlight and reiterate that opioids are completely safe and appropriate for acute pain relief in patients who consume cannabis. Then you're asked, Doc, what could cause my surgery to be delayed or canceled? And for this response, once you scan the QR code, perhaps just type in some of the reasons why you have canceled a case or you've heard a case has been canceled or delayed. Anyone here ever had their case canceled or delayed, or you've heard about that in someone? Surgeon uncomfortable with cannabis use. Great, haven't had a case canceled or delayed. I wish I could say that. Unfortunately, there have been, I have had to cancel cases, but for the obvious reasons, obviously you cannot violate NPO instructions. Okay, so this is not specific to cannabis. An obvious reason for a case to get delayed is if you eat after midnight. So there's no having an edible after midnight. They can also say you can have clear liquids up until 2 hours before your procedure. So that's clear liquids, it's the coffee with cream. And so a tincture is also a clear liquid. And it's also common sense to make sure that on the day of surgery that you present clear-minded and able to provide informed consent. But that's common sense for anyone, any substance. So you see, at the current time, there's no evidence to suggest that we should cancel patients who on the day of surgery report clear-minded and just so happen to have taken a cannabinoid-based tincture, edible, or capsule the night before. But it is a ASRA grade C recommendation, though, to delay surgery for 2 hours after smoking cannabis, given the higher risk of myocardial ischemic event. Speaking of MI risk, the patient says to you, I heard that people who smoke marijuana right before surgery have a higher risk of having a heart attack. Is that true? And so what do you tell them? I may have given the answer a little bit, but do you say A, yes, it is true, no, it's not, or C, possibly true? So it looks like who has it here? Who's leading here? The notice. There was one retrospective population-based cohort study that found that patients diagnosed with cannabis use disorder were at an increased risk of having a perioperative MI. There were several limitations to the study. One was that they didn't adequately account for other factors that are associated with a myocardial ischemic event. And it is challenging to study the effects of cannabis alone because patients concomitantly use both tobacco and cannabis. And cannabinoids like tobacco may lower the anginal threshold in those with chronic stable angina, but it has not been shown that it contributes to, or cannabis use contributes to, the development of coronary artery disease. The patient then asks, how long before surgery should I refrain from inhaling cannabis? So what are you telling people? They should stop smoking 10 days before, they should stop vaping 7 days before, they should stop smoking 3 days before, or you tell them, don't stop, just keep going. No changes. Does one more person want to vote? I think we typically have 6 voters here on the polls. One more vote. Anyone like to cast? So it looks like most people are saying never. In general, I would say that smoking anything, including cannabis, is discouraged. And I tend to, as an anesthesiologist, counsel all smokers on the potential risks of respiratory complications. And these risks are laryngospasm and bronchospasm and many more. And so in general, given the limited evidence available, I believe it's prudent and reasonable to, at a minimum, discourage cannabis inhalation within 72 hours of general anesthesia. So as reported in the ASRA guidelines, 72 hours is when we can expect dissipation of heart rate effects and decreased pharyngeal and uvula edema. There's insufficient evidence to suggest that non-smoke routes of administration or CBD dominant products adversely affect the cardiovascular or respiratory systems. And let's be mindful that 24 to 72 hours of cessation in those who chronically or heavily use the cannabinoid THC specifically may result in symptoms associated with cannabis withdrawal syndrome. On this QR code here, you'd find a nice article that outlines the diagnostic criteria for cannabis withdrawal syndrome and treatment options, as well as the time course here. The symptoms are not life-threatening, but they can include irritability, sweating, anxiety, and tremor. And the treatment really is supportive. And if it's severe, the symptoms are severe, you can give pharmacologic agents such as dronabinol or benzodiazepines, depending on, what you have on formulary. Speaking of dronabinol utilization, also published in Regional Anesthesia and Pain Medicine was this e-poster. It was a retrospective study looking at reasons for which inpatients were given dronabinol after an orthopedic surgery. So they had 249 patients in this study, and 91% of them used cannabis prior to admission. And listed here in order are the reasons for which they were given dronabinol. Interestingly, reasons number 1 and 2 are reasons why in medical programs everywhere patients are saying they are using cannabis products, and that is for pain management and for sleep disorders. But they were also given dronabinol for appetite stimulation after surgery, cannabis withdrawal, and lastly, post-operative nausea and vomiting. So your patient then says, oh, speaking of post-operative nausea and vomiting, I've had it before, or I often have it. Can cannabis help with this? And so what do you tell that patient? Does cannabis treat post-operative nausea and vomiting? Yes? No? Maybe so? Well, despite what we saw from the study on the dronabinol utilization, cannabis is not currently a proven treatment modality for postoperative nausea and vomiting. And we currently attempt to mitigate the occurrence of nausea and vomiting postoperatively by routinely screening all patients for their risks in the preoperative period. And currently, there really is no evidence to suggest that we should alter this approach. In coming to a close, I would like to remind you that cannabis is a medically relevant substance that causes widespread physiologic changes with importance in the perioperative period. And additionally, cannabinoids have the potential to interact with other medications as well as anesthetics. All patients should be screened for cannabis use so that we may discuss risks that are relevant to them. We should not be performing universal toxicology screenings to assess for acute intoxication. This is an area of emerging data, but given that specifically smoking cannabis can negatively affect airway resistance, cardiovascular physiology, and cognition, it is reasonable to consider discouraging cannabis smoking use prior to surgery, similar to tobacco smoking, and especially within 72 hours of surgery. Postponement of elective procedures for those who have smoked cannabis within 2 hours is reasonable, given the risk of acute MI. With compassion, we should assess for heavy cannabis use and for absence symptoms, and treat severe cannabis withdrawal with dronabinol or benzodiazepines as available on your formulary if, again, the symptoms are severe. There is insufficient evidence to suggest that CBD dominant or non-smoked routes of cannabinoid use, that they have the same effects or detrimental effects on physiology as the smoked routes or THC dominant products. Thank you so much again for your attention and your time, your participation. In this QR code, you could reach out to me. There's my email address here, but at this time, I'd like to stop sharing my screen and answer any questions that you may have.
Yes, thank you so much. That was a great presentation. I really enjoyed it. If anyone has any questions, feel free to raise your hand or put them in the chat, and we will try to address as much as we can. All right, I see Nurse Laura raising her hand.
Yeah, I was looking for the raise hand thing, but I was just curious. I saw when you were showing the electronic health record with where all the places that current cannabis use is it still also listed under illegal drug use? Is it still also captured there in like their social history? I was just curious.
In Maryland, where I practice, it's no longer placed on, it's no longer listed under illegal use or illicit use. I think there was something, or illicit drugs. It was taken from that spot, and its own spot was created appropriately. So, given, the legality here in the state. But I think I offer that suggestion on how we're documenting to give ideas, maybe where others practice, to be accurate in the terminology, encourage the use of cannabis over marijuana, to acknowledge that there are multiple routes of administration, that it's not just affecting the pulmonary system, that it can have, effects on chronic pain. And so that is why it sits under our psych and social section. Thank you for that question.
Right, well, I actually have a question too, while we're waiting for other people to join in. I was just wondering, you talked a little bit about working with patients, and you are a consultant and help with that, like managing. And I was just curious, how you approach patients who want to use cannabis but have never used it before themselves, only want to use that medicinal approach because of whatever they're dealing with currently.
And so is your question related to use for acute pain or chronic pain? I typically am consulted on the use of cannabis for chronic pain, but particularly for those who are interested, I'm usually like the bridge between, the patient. I'm usually referred by a chronic pain physician who is okay. Again, are cannabis friendly in that they know that when they check the urine, for example, that metabolites of cannabinoids will be present. And so I'm already getting a patient who typically is in that system of or pain management. And I really just take them, I meet them where they are. There's so much misinformation out there, so many questions. And I just try to answer them, one at a time. I think the biggest thing is they think they have to be high in order to get relief. Many of them think they just have to smoke it. They may recall back to when they were teenagers or a different time when it was not being used as, medicine. And so they're reflecting back on that and wondering if there's another way. And so I, really on an individual basis, kind of meet them where they are. And as they, explore the potential that cannabis may have for them, it's not for everyone. It's not for all things. But I'm that guide to help them in their exploration.
Awesome. Thank you.
Thank you. Thank you for that, Alicia.
I just want to say, since no one else is asking a question, that it was so good. And I've seen it before, and so I knew some of the answers, but it was so good. Once again, this is such good information presented in a really balanced way. Thank you for doing what you do and trying to share this with other people who might not be as informed or comfortable learning about it.
Thank you.
So I do have one quick question. I'm the one that is the OR circulator. So I'm in Minnesota where it's rec was just newly legal at the end of last year. Medical has been on board, but it's still been fairly quiet. People aren't asking routinely. What do you suggest is the best approach in spreading that information appropriately? Like I've had CRNAs ask me that know what I'm doing as a private consultant and a master's candidate. So they will ask, hey, what's the latest information? But it's kind of few and far between. I guess what do you feel is the best culture change?
In terms of getting that information out there,
Yeah.
Obviously, having people like myself, presentations if they're open to grand rounds, having, their peers maybe present to them in terms of the information out there, sharing the ASRA guidelines with them, or if you're sharing a patient, maybe send the guidelines with the patient, share that information through the patient, the in-between between you and the providers. And I thought the first thing I thought when you asked that question is like, how do I get the information out there? I've had colleagues tell me they listen to how I interview patients and the way I do it and the tone in which I take, they say they mimic me now. And that speaks a lot to me that they're hearing me and they're seeing that response. And so it just, hopefully it's contagious, that then someone can hear them asking and inquiring and having those conversations and those teachable moments. And so maybe a domino effect that way, if we can't reach people widespread with like a grand rounds or some sort of, presentation for the
presentation. That's helpful on the ASRA guidelines. So that at least kind of gives me some kind of backbone, I guess.
Yes. And they have, summaries of those guidelines too, to make it easier to digest because it's pretty thick. But like I said, you could, present that with them or have the patient, take it with them on the day of.
Sure. Okay, perfect. Thank you so much.
Thank you. That's a great question.
Looks like we have another question coming in from Jason with his hand raised.
So my wife had surgery, but one of her problems was she needed her cannabis to control her pain and her nausea from her cancer. And she was having a DVT removed. It was about 3 foot long in her leg. And we had a wonderful conversation with the anesthesiologist. We went through and we explained the cannabis use, and the anesthesiologist said, "Oh, since you had problems with nausea before," they gave her extra medication, and she had a wonderful experience. And we're both critical care nurses, and so it was a way that at the practitioner level with patient, we could interact with them. But the hospital administration and some of the doctors are, even though we're in Michigan, they don't like cannabis use and they're resistant to learning. Have you found a resistance in your administration in being resistant and getting information out and interacting and providing educational courses on cannabis? Or is it just you kind of spreading it, or does your administration support you in that?
Thank you for sharing your story. You know, what I have found recently, and I know Nurse Laura is on here and she's done this with me, is they're more and more curious now, and they're more open-minded. And I have found that they have been more receptive to this discussion and how system-wide we can improve the patient experience. So, you know, we're very new into this, but I find a lot more openness and the ability to have these conversations than before.
Great. If anyone else has more questions, please raise a hand or put it in the chat. I do want to mention for anyone not seeing this in the chat that Dr. Asike does have a course with us at ACS. It's an approach to cannabis and anesthesia. You can find it on the ACS website, and we do have the link in the chat now. It's available at a discount to members, but everyone is able to access it and take the course. So just so everyone knows. Right. Any more questions coming in? Well, I'm actually pretty curious too. You do serve on a few boards in Maryland, and I'm just curious about what that experience has been like and just what your role has been.
You know, it's just been a great opportunity to have a seat at the table as a physician to just, share, some of the concerns or to kind of look out for to the public health of the patients and providers. It's been a great experience. It's a lot for me to learn. You know, I'm a clinician, but my heart is serving and really serving people. And so this has just been a perfect win-win for me and combination of the things that I enjoy doing and feel called to do.
Oh, that's really great. And then how does that play into you're a veteran. And so how have you gone from being a veteran, getting in this field, getting into cannabis? What has that experience been like?
Well, it's great not just to be a veteran, but to be, I'm a pain physician trained in all the pain management techniques that you hear about. And, I share the story that, I used to be one of those doctors, didn't know anything about cannabis. And from the military, a total rule follower. And I would find my approach to pharmacologic management of pain very conservative. And I would, cringe, if often, a patient had, metabolites, cannabinoid metabolites in their urine. We were taught that it was a gateway drug and that you would have to discharge the patient. So I find myself in a completely different space now because I used to be that doctor who would discharge. And I know you hear a lot of things about that. It's just we didn't know, or I'm going to speak for myself that I didn't know. And so to have come full circle to now be an advocate for cannabis as medicine, the science makes sense. And again, if we can lead with compassion and empathy, and provide patients with safer alternatives for pain management, safer alternatives, not just for the physical pain, but the emotional pain that comes with life and war and all the things. I think that speaks to humanity and what I like, to be a part of and like to see more of. As, a veteran, a lot of the discussions really reach home for me. And what I'd like to see, obviously, at the federal level is not just, cannabis care being legalized and supported, but all the things that go with that, which means affordability and improved access for veterans. I like to see that as well.
Awesome. Yeah, I think that's a great point. I feel like in cannabis medicine, it's the science is making sense and it has that compassion side to it too. It's so important.